Hello everyone and welcome. Today we're going to talk about the anatomy and physiology of the cranial nerves and associated organs. So the cranial nerves are a set of 12 paired nerves that arise directly from the brain. The first two, which are the olfactory and optic nerves, arise from the cerebrum, while the remaining 10 emerge from the brainstem. Now, these nerves are named in relation to their function, and they also have Roman numerals to identify them, so from 1 to 12. So here we have a brain, and there is a lot of information to take in from this slide, but essentially we're just having a look at the brain, and the colorful nerves there shown in the image on the right just represent the cranial nerves. So remember that they come in pairs. So we're going to have two olfactory nerves, one in the left hemisphere, one in the right hemisphere, two optic nerves, two oculomotor nerves, and so on. So cranial nerve number 1 is the olfactory nerve, shown right here. Cranial nerve number 2 is the optic, shown in green here. Cranial nerve number 3 is the oculo-motor, in yellow. Then we have the trochlear nerves, here in purple. Next, cranial nerve number 5 is the trigeminal, this really big one here. And we can see it has 3 divisions, which we will talk about soon. Cranial nerve number 6 is the abducens, shown here in purple. Number 7 is the facial nerve, right here in green. Then cranial nerve number 8 is the vestibulocochlear, in pink here. Number 9 is the glossopharyngeal. Then we have the vagus nerve as cranial nerve 10. Cranial nerve number 11 is the cranial accessory nerve, shown right here. And then lastly, cranial nerve 12 is the hypoglossal. So it is quite important to know where each cranial nerve is in relation to the brain. So try and pause this slide, study it quite a bit so you're familiar with their anatomical position. Alright, so while searching, doing my research for this video, I came across the most absurd mnemonic ever to remember the cranial nerves. And I'm not sure if this will ever help anyone, but it goes something like this. Only overgrown orangutans try to aggravate fat vagrants getting vodka and hamburgers. Like, what? But anyways, now we're going to talk about essentially the foramina that each cranial nerve uses to leave the cranial cavity to go and innervate whatever structures that they innervate. So this image here is quite complicated. Here on the right hand side, I've named each foramina that is relevant to the cranial nerves. Because not all of them are. Some are used by arteries, for example. So the first one here, number 1 in this image, is the optic canal, and it is used by the optic nerve. It's how the optic nerve leaves the cranial cavity. Number 2 here is quite important. It is the superior orbital fissure, and the oculomotor, the trochlear, ophthalmic, and abducens nerves all leave the skull through this opening. Now the ophthalmic nerve is one of those branches that I talked about, one of the branches of the trigeminal nerve. Next we have the foramen rotundum, which is used by the second branch of the trigeminal, which is the maxillary nerve. Then we have the foramen ovale, which is used by the mandibular branch of the trigeminal, or the third branch. Next we have here number 5, the internal acoustic meatus, and the facial nerve and the vestibulocochlear nerve are both going to leave the skull through this aperture. Next we have the jugular foramen, which is quite important. The glossopharyngeal, the vagus, and the accessory nerves all leave the skull through this opening. Then number 7 is the foramen magnum. And number 8 there is the hypoglossal canal. So that's where the hypoglossal nerve is going to leave the cranial cavity. And lastly, number 13 here in the image is the cribriform plate, and that's how the olfactory nerve is going to leave the cranial cavity to innervate the nasal cavity. So let's talk now about the olfactory nerve, that is the cranial nerve 1. It will leave through the cribriform plate here. And so here we have the two olfactory nerves. They come together to form this olfactory bulb. And there we have it. Through the cribriform plate, they will give off a bunch of little branches that will innervate the nasal cavity. The function of this nerve is to provide a sense of smell. So it is a completely sensory nerve, more specifically of a special visceral sensory modality. And damage to this nerve leads to anosmia, which is the absence of the sense of smell. For examination of this nerve, usually patients are asked to identify strong smells. Most of the time, we can use coffee. So next we have the optic nerve. This nerve is responsible for vision, and it will innervate the retina of the eyes, so this posterior portion here. And as you can see, we have the two optic nerves, right? One here, one there. And they're going to come together at the optic chiasm, where some fibers are going to decussate, while others are going to remain ipsilateral. So the fibers innervating the medial retina, also known as the nasal retina, as the nose would sit around here, so they're closer to the nose. These will decussate and go to the other side of the brain, while the fibers innervating the most lateral retina, also known as the temporal retina, these are going to remain ipsilateral, so they're not going to decussate at the optic chiasm. Now, all this information essentially travels to the primary visual cortex, which is this area here in the occipital lobes, so all the way in the back of the brain. This is a purely sensory nerve, more specifically of a special somatic sensory modality, and it will leave the skull through the optic canal to travel here to innervate the eyes. Now, damage to this nerve will lead to loss of vision. Next, we have the oculomotor nerve, that is cranial nerve 3. It is going to provide motor and parasympathetic innervation to some of the structures within the bony orbit. So it is going to innervate the majority of the extraocular muscles, namely the superior rectus, which is shown here, the medial rectus, all the way there in the back. So here on top we have the lateral rectus, and then if we cut through, we can see there the medial rectus, and the oculomotor nerve innervates the medial and not the lateral rectus. So here we can see the medial rectus here and the superior rectus mentioned just before. It also innervates the inferior rectus, shown right there. It will also innervate the levator palpebrae superioris, which is this muscle here, which is involved in opening the eye, so elevating the eyelids. And it will also innervate the inferior oblique, shown right there, also here. This nerve, the oculomotor nerve, is also going to innervate the sphincter pupillae, which is responsible for constricting the pupils, and will also innervate the ciliary muscles, which are involved in accommodation of the lens. So damage to this nerve leads to ptosis. This is because of the levator palpebrae superioris, which will be unable to elevate the eyelid, a down and out position of the eyeball. So the patients will be unable to elevate, depress, or adduct the eye, as all these muscles mentioned are going to be weak or paralyzed. And you're also going to have a dilated pupil. Next, we have the trochlear nerve, which is cranial nerve 4. And this is the only cranial nerve that exits from a posterior aspect of the midbrain. All of the other nerves exit from an anterior aspect. Now, this nerve is quite simple, as it will only provide motor innervation to the superior oblique. So in this image here, this muscle right here is the superior oblique, and this is a superior view of the eye, of the eyeball. And just so you can orient yourselves better, here we have the lateral rectus, the medial rectus, and the inferior rectus right there. So the superior oblique passes through this fibrous structure here, which is called the trochlea. And that is why the trochlear nerve has its name. It's called trochlear nerve. Damage to this nerve is going to cause paralysis or weakness of this muscle, and this is going to lead to diplopia or double vision that is exacerbated when looking downwards and inwards. So, for example, when reading a book or walking down the stairs. Next, we have the trigeminal nerve, which is cranial nerve 5, and this nerve is associated with the derivatives of the first pharyngeal arch. As the name implies, it will have 3 branches. So the first one being the ophthalmic nerve, the second being the maxillary nerve, and the third being the mandibular nerve. These nerves are going to innervate according to these areas here. So we have the ophthalmic zone, the maxillary zone, and the mandibular zone. So these 3 divisions innervate the skin, mucous membranes, and sinuses of the face, providing sensory information in accordance to these zones. Now only the mandibular nerve has motor fibers. And so mandibular nerve here. This is going to innervate the muscles of mastication, these being the medial and lateral pterygoids, the masseter, and the temporalis. But it will also innervate some other first pharyngeal arch derivatives, such as the anterior belly of the digastric, the mylohyoid, tensor villi palatini, and the tensor tympani. Now, about how these nerves leave the cranial cavity. The ophthalmic nerve leaves through the superior orbital fissure, the maxillary nerve through the foramen rotundum, and the mandibular nerve through the foramen ovale. So, damage to the trigeminal nerve is going to lead to sensory loss of the face according to these areas, so depending on which branch was damaged. It is also going to lead to an inability to clench the jaw or open the mouth and move the mandible to the right or to the left. And this is due to paralysis of the muscles of mastication. Now, damage to the trigeminal may also present as an absent corneal reflex, and this is mainly to damage to the ophthalmic nerve. So as you touch the cornea, this sensory information is carried by the ophthalmic nerve. And so if there is a damage to the ophthalmic nerve, there will be no sensation in the cornea, and so the corneal reflex will be absent. Next, we have the Abducens nerve, which is cranial nerve 6. This is quite a simple nerve. It only innervates the lateral rectus muscle and has a purely somatic motor function. So going back here to these muscles of the eye, the Abducens nerve is going to innervate this muscle right here, which is the lateral rectus. And the lateral rectus serves the function of abducting the eyeball. So this means looking away from the midline, so let's say away from the nose. And if you know the function of the lateral rectus, then the abducens will be quite clear why it has this name. Well, because it abducts the eyeball. Damage to this nerve will lead to diplopia or double vision with a resting position in adduction, so towards the nose, and an inability to abduct the eye. Next, we have the facial nerve, which is cranial nerve 7. and this is associated with the derivatives of the second pharyngeal arch. This nerve has multiple modalities, so it's going to provide motor innervation to the muscles of facial expression. So all of these muscles you can see here in the face. It will provide sensory innervation to the concha of the external ear, and taste sensation to the anterior 2/3 of the tongue. This is quite important. Now, it will also provide parasympathetic innervation to the submandibular and sublingual salivary glands, to the nasal, palatine, and pharyngeal mucous glands, and to the lacrimal glands. So the facial nerve leaves the cranial cavity through the internal acoustic meatus, shown here by this circle, and it then leaves the cranium via the stylomastoid foramen. From here, it will go on to innervate the face. Now, damage to this nerve may lead to what is called Bell's palsy, and this is shown here by this image. A patient with Bell's palsy is going to have paralysis of the muscles of facial expression on the side of the face that is affected. They're also going to experience drooling, muscle twitches in the face, a dry eye and mouth, and this is because, remember, the facial nerve provides parasympathetic innervation to the lacrimal glands and some salivary glands. The patient is going to experience some headache, some sensitivity to sound, and irritation of the eye on the involved side. Next, we have the Vestibulocochlear nerve, which is the cranial nerve 8. And this nerve comprises of two fibers, the vestibular fibers and the cochlear fibers. So, as we can see here, we have two nerves here. This little one is the facial nerve that we just talked about, as it leaves the cranial cavity through the internal acoustic meatus. And now this thicker one is the vestibulocochlear nerve, which also leaves the cranial cavity through the same aperture. Now the vestibulocochlear nerve is going to divide into two nerves. The vestibular nerve, which is going to innervate here the vestibular apparatus, and the cochlear nerve, which is going to innervate the cochlea. So the vestibular nerve is responsible for balance, and the cochlear nerve is responsible for hearing. So damage to the vestibular nerve leads to vertigo and nystagmus, loss of balance, and nausea and vomiting, while damage to the cochlear nerve leads to hearing loss and tinnitus, which is this false sense of ringing or buzzing sound. Next, cranial nerve 9 is the Glossopharyngeal Nerve, and this nerve is associated with the derivatives of the third pharyngeal arch. This nerve is going to provide many functions. So it provides sensory innervation to the oropharynx, the carotid body and sinus, the posterior 1/3 of the tongue, and the middle ear and eustachian tube. Now, the glossopharyngeal nerve provides taste sensation to the posterior 1/3 of the tongue. So remember, we talked about taste in the anterior 2/3 of the tongue, and that was the facial nerve. So the posterior 1/3 is the glossopharyngeal nerve. It is going to supply parasympathetic innervation to the parotid gland. So that is the last salivary gland that was missing, and motor innervation to the stylopharyngeus muscle. So here in this image you can see some of the organs innervated by the glossopharyngeal nerve. So this nerve leaves the cranial cavity through the jugular foramen, and damage may lead to an absent gag reflex, as it provides sensory innervation to the oropharynx. Next, we have the almighty vagus nerve, which is cranial nerve 10, and it will innervate pretty much anything you can think of. It leaves the cranial cavity as well through the jugular foramen. And here, in this image, we have a depiction of the parasympathetic nervous system. And as we can see here, the cranial nerve 10, which is vagus nerve, is going to innervate all of these structures. So it innervates the skin in the concha of the ear, the pharynx, the larynx, the trachea, the bronchi, the lungs, the heart, the esophagus, the stomach, the gallbladder, the liver, the pancreas, the small intestine, and up to the splenic flexure of the colon. So let's go into a bit more detail here. So the vagus nerve is going to provide general somatic sensory innervation to the skin of the posterior external auditory canal and the external ear by the auricular nerve. It's going to give a general visceral sensation to the laryngopharynx and the superior larynx, also the heart and the GI tract, all the way to the splenic flexure. Now it has a minor role in taste sensation, innervating the epiglottis and the root of the tongue. And in terms of motor innervation, it will supply the superior, middle, and inferior pharyngeal constrictor muscles, the palatopharyngeal muscle, and the salpingopharyngeus muscle. It also innervates the intrinsic muscles of the larynx by the recurrent laryngeal nerve, which is shown here. So we have the vagus coming off, and there is this branch here, which is going to go under the aortic arch and come back up. That is the recurrent laryngeal nerve. The vagus is also going to provide motor innervation to the palatoglossus muscle and the majority of the soft palate. Now, in terms of parasympathetic innervation, the vagus is the main parasympathetic outflow in the thorax and the abdomen, mainly providing parasympathetic innervation to the heart and gastrointestinal organs. So if you're thinking parasympathetic innervation in the thorax and abdomen, think of the vagus nerve. So again, the same image showing all of these structures that it provides parasympathetic innervation to. And because the vagus is so extensive, there can be damage to the nerve in multiple areas and lead to various different impairments. But in terms of the cranial nerve examination, damage to the vagus leads to an absent gag reflex as well, but in this time, it will play the motor role of the gag reflex. So we said the glossopharyngeal will provide sensation to the oropharynx. Now the vagus nerve is going to provide that motor innervation to allow the gag reflex. Next we have cranial nerve 11, which is the accessory nerve. And this has a purely somatic motor function as it innervates the sternocleidomastoid and the trapezius. So here we have the sternocleidomastoid and the trapezius. Now the accessory nerve may be divided into a spinal and to a cranial component. So the spinal component is actually formed by neurons in the upper spinal cord from around C1 up to C5, C6. These fibers are going to come together and travel superiorly to enter the cranial cavity by the foramen magnum. And then we have the cranial component, which is smaller and arises in the lateral aspect of the medulla. Both the spinal and cranial components leave the skull via the jugular foramen. However, the cranial component of the accessory nerve is going to combine with the vagus and also be distributed through the vagus nerve. And so a lot of the times the cranial component of the accessory nerve is just considered to be part of the vagus nerve. Now, damage to this nerve leads to muscle wasting and the inability to rotate the head or shrug the shoulders, as the sternocleidomastoid and the trapezium are going to be paralyzed. Finally, we have the hypoglossal nerve, which is cranial nerve 12, and it literally stands for under the tongue, and this will already give you some information of its function. So the hypoglossal nerve is going to innervate all the extrinsic and intrinsic muscles of the tongue, except for the palatoglossus. Like we said, this muscle is innervated by the vagus. It has a pure motor function. So here we have some of the muscles of the tongue there. And damage to this nerve will lead to the deviation of the tongue towards the damaged side, also muscle wasting and fasciculations or muscle twitches. So finally, we have here a table just summing up the modalities of each nerve. So the olfactory, sensory, optic, sensory, oculomotor is motor. Trochlear provides also only motor innervation. Trigeminal will provide both sensory and motor innervation. As we talked before, the mandibular branch of the trigeminal has motor fibers. The abducens is only motor, facial, both. Vestibulocochlear, sensory. Glossopharyngeal, both. Vagus, both. Accessory, motor innervation. And the hypoglossal, also just motor innervation. And now, good mnemonic to remember the modalities of each cranial nerve is: some say marry money, but my brother says big brains matter most. Thank you for watching this video. If you enjoyed, please leave a like and subscribe. I really hope this was helpful.